Hello, my name is Dr. Phil Boyle. I work as a fertility specialist in Dublin, Ireland. I'm trained as a family physician, and for the last 20 plus years, I've been working exclusively in the area of restorative fertility treatment. So I wish to share with you some of my experience of this approach and encourage you to consider it as an option if you have fertility issues yourselves. So the title of my presentation is Fertility Restoration Through Cycle Tracking. So apologies, I'm just trying to, there we go. So for conflicts of interest, I am currently the president of the International Institute for Restorative Reproductive Medicine. We actually are based in the United Kingdom, and we represent restorative reproductive medicine internationally. So I have an interest to promote this restorative technique. I am also the co-owner and developer of the fertility app ChartNeo at our website chartneo.com. So looking at our app, it is a scientific cycle charting method for women's health and fertility treatment. We work with a team, and you can work on your own as a couple. If you decide to download the app yourselves, there's a certain amount you can do entirely on your own, but you'll always do better with additional professional input. And the first person you would connect with would be your fertility advisor. Fertility advisors are listed on our app, where you could identify somebody trained in restorative fertility techniques and fertility cycle tracking. We work with billings providers, symptothermal method, Creighton method, or any kind of cycle tracking system that would be applicable through our charting app. If the fertility advisor feels you need medical support, then they would link you in with your local fertility doctor who would be familiar with restorative techniques. In the United Kingdom, Dr. Nell Dumpert is probably the best person to connect with, and Frida McMahon, who is with you today, will explain to you the role of the fertility advisor. We go right back to basics and right back to simplicity, and it's all about the mucus. The woman would be able to identify her window of fertility when cervical mucus is present mid-cycle, typically between days 11 and 14 of the cycle. The mucus can be stretched off toilet tissue. You determine how far does it stretch and what is the color. These are the two key things you would look out for. With our app, we help you to document and record this with greater detail. Ultimately, that simple assessment identifies when you have a mature follicle, which is just about to rupture to release the egg. When the cervical mucus disappears, it tells us that rupture has happened. When the cervical mucus is present, it tells you a big follicle is present and you're at your fertile time. Ultrasound is recommended to completely validate what the cervical mucus suggests, especially in the world of fertility treatment. And it's the cervix that produces this biological fluid, the cervical fluid, under the influence of estrogen coming from a mature follicle. So that's where it comes from, and it lets you know that you're at your window of fertility where fertilization is possible. So a very simple explanation of our tracking system shows the bleeding days, dry days, mucus days, and the last day of cervical mucus is the peak day and presumed ovulation, presumed on the basis of the fertility cycle chart, but verified if you have an ultrasound to see that rupture occurs. With our fertility app, it's not just about the bleeding and mucus. We also encourage those who need it to document the temperature shift. Temperature remains persistently low until ovulation occurs, and after ovulation, you get a temperature shift that can confirm that you're producing progesterone and it is likely ovulation has happened. with this extra assessment of documenting temperature, it boosts your confidence that your observations are accurate and you truly are identifying your time of presumed ovulation. We have an additional marker with urinary hormone assessment, where with something like a clear blue ovarian monitor or something similar, you can document that estrogen is present when the clear blue monitor shows high. That tells us that we're approaching the fertile time. And in this example, from one of the couples that we have treated, her clear blue monitor showed high a day before her, in fact, 2 days before cervical mucus was evident. So we could tell from the ovarian monitor, even before mucus appeared, that fertility, the fertile time was approaching, but the most fertile time is when the mucus was actually there. And that was day 11 and day 12 in this example. In addition, with our app, you can document the medications you've taken. You can document the days of intercourse, and very much we encourage checking your bloods 7 days after ovulation. We even have a facility for documenting intensity of period pain, low mood, anxiety, depression, anything you may feel, document it on our app, because we want you to feel good, to know that you have optimum fertility. Incredibly, we can identify at-risk cycles even before you try to get pregnant. So this is a radical departure in the world of infertility and gynecology. Generally, with regard to gynecologists, if you're trying to get pregnant and you're under 35, everybody is told it's normal to take a year to get pregnant. Don't worry about it. Everything's fine. In fact, it's even normal to take up to 2 years to get pregnant, because researchers have found couples who are not pregnant at the end of the first year of intercourse without any fertility treatment, if they continue to have intercourse for another year without any fertility treatment, 50% of couples will get pregnant in the second year, which is higher than most fertility clinics. So, but the problem is, time is marching on. If you have a more serious underlying fertility issue, then you've lost a year or two before you could actually step in and intervene and treat that. So that's where the trade-off is. And our view is you don't need even to wait one cycle. We can identify at-risk cycles even before you attempt fertilization. The first 2 lines are examples of normal fertility charting patterns, but the third line is suggestive. Remember, a fertility chart cannot diagnose, it suggests, but is suggestive of late ovulation and likely polycystic ovaries. The fourth line shows a very short second half of the cycle that ovulation is identified. The second half of the cycle is very short, it's only 7 days. That's called the luteal phase, the days after you ovulate. And when we see this, it's much harder to get pregnant. And if you do conceive, much more likely to end in miscarriage. So we can identify couples with impaired fertility from the fertility charting pattern, even without a blood test. Based on what the fertility pattern looks like, we can identify at-risk cycles. So many couples who have decided, well, we're not ready to have a family yet, we're going to postpone having children. Many couples would choose hormonal suppression through contraception, the birth control pill in particular, to suppress ovulation, because we've decided we don't want to start our family just yet for maybe 3, 4, or 5 years. And I would often ask the question, well, how do you know you don't have impaired fertility in the first place? The younger you are when you start your family, the better the chance you're going to get success. So why don't you track your fertility cycle, get an assessment of your fertility health, and use this system. It's as reliable as hormonal contraception. Use this to avoid having a surprise pregnancy, and also to reflect what your gynecological health is like, so that you may intervene and balance your cycle when the time comes that you would like to optimize the preconception environment. But also, even if you're not trying to get pregnant, if you have premenstrual symptoms, if you have period pain, if you have genital fatigue, we can help with all of these things to optimize your general health and improve your general health as well as your fertility health. These are other examples of impaired fertility where we have limited cervical mucus on the first line that's associated with endometriosis or pelvic adhesions in particular. The second line is a little bit more subtle. It shows brown bleeding throughout the menstrual flow, and that's suggestive of an endometrial infection, which is also very treatable. And the third line is a little bit more obvious. This affects up to 15% of couples who are trying to get pregnant, where there's spotting for 3 to 4 days before the menstrual period begins. That indicates that the endometrium is breaking down prematurely, very commonly due to low progesterone, which, if identified and treated preemptively, can reduce the risk of miscarriage and infertility both. The last line, where you get spotting in the middle of the cycle, is suggestive of a polyp or maybe even a fibroid, some distortion of the endometrium that causes spotting in the middle of the cycle. And that's identified by ultrasound or further surgical assessment. So remember, with our app at ChartNeo, we can identify impaired fertility even before you attempt to conceive. You don't need to wait a year or more in order to identify that impaired fertility may be present. More than that, we can do a blood test 7 days after you ovulate. And this is a radical new concept because the typical assessment for hormones is on day 21 of the cycle, where your gynecologist or GP would say, let's see if you're ovulating. Let's do a blood test on day 21 of your cycle to check your progesterone levels. The threshold for that is a reading of 30 nanomoles per liter. And the guide is, if you have a progesterone level above 30 nanomoles per liter, you're ovulating and we're done. It's a yes or no question. Either you're ovulating or you're not. So for me, that's a very blunt instrument, which means it is a very low ability to identify subtle hormone deficiencies that we would commonly identify with a more detailed assessment. The difference with our assessment is we measure a combination of estrogen and progesterone, and we don't just do it on day 21 of the cycle. We test your blood sample 7 days after the peak or presumed ovulation. So the peak day moves around a lot. It could be as early as day 11 or as late as day 17 or anywhere in between. And if you know for sure where the mucus changes and we have presumed ovulation, then we can measure the maximum surge of your hormones, which typically occurs 7 days after presumed ovulation. And our interpretation isn't a yes or no question. In fact, if you have a peak day in a monthly cycle, we assume the vast majority of women are ovulating. And our question is, when you ovulate, what is the quality of your ovulation? So it's a very, very different question, a different way we time the blood test, and we look for 2 blood tests rather than 1. And we interpret it differently, not a yes or no, but what is the quality? And if you ovulate with suboptimal levels of progesterone and estradiol, using a higher reference range, we would insist progesterone should be above 60 and estradiol above 400. If your blood test results are below these parameters, it is a suboptimal or impaired ovulation, where it'll be harder but not impossible to get pregnant, and it'll also be an increased risk of miscarriage. So we typically recommend doing blood tests if you have had 6 balanced cycles of relaxed, enjoyable intercourse during the fertile time, and you've not achieved fertilization. Well, anywhere after 6 balanced cycles, then it is time to consider hormone assessment. So we don't wait a year or more. And in fact, we would recommend that we do these blood tests earlier. If your fertility charting pattern indicates an impaired cycle, then we'd say, let's not wait. Let's intervene even before you try for the very first cycle. I would also argue any couple where the female age is 38 or older should consider hormone assessment prior to attempting fertilization, because fertility in fact, it starts to decline from 35 onwards, but it is significantly declined even from age 38. With cycle assessment and hormone balancing, we can significantly improve your chances of getting pregnant and reduce the risk of miscarriage for women up to and including the age of 42. From 43 onwards, we have notable exceptions where we can get success, but we would definitely struggle more. In fact, we have somebody in our program age 45 who's currently expecting, and she had her first baby with us at 43. But while for her it's 100% successful, she's a little bit more exceptional and lucky, and she knows that. So when we're working with couples, we try to give you an assessment. Well, if we had 100 couples like you, how many do we think it may work for? And our assessment of that varies depending on your overall history, your presentation, and what your cycle looks like. So looking at our statistics, conceiving through neofertility, we can get a 52% overall success rate, and we've published that through the experience of our practice. We get a 32% live birth rate for couples who have previously tried and failed with IVF, and an 80% live birth rate for couples with a history of 3 or more miscarriages. That's our average, and the details of these studies are outlined as we progress, whereby looking at our first study that was published using the Creighton model chart and restorative reproductive medicine with NAPRO technology, which is what we did prior to becoming neofertility. We published the results of our data, and the link is available here, but we got a 52.8% adjusted live birth rate with live table analysis. That was for a female age of nearly 36 years of age, an average of 5.5 years trying to conceive, and we included the couples who had previously tried and failed with IVF. And even with that particularly difficult fertility group, we were able to achieve success for half of the couples. If we specifically looked at those who were at the point where they tried and failed IVF an average of 2 times, and this is often where internationally, most couples will try IVF about 2 times and then they give up. So they were beyond IVF. Even in that group, we were still able to get an adjusted live birth rate of 32%. So roughly 1 couple in 3, we could still achieve success where they were, like I say, beyond IVF. This is for an average female age of 37 and for 5 years of trying to conceive. So it's a difficult group. And even in that most difficult scenario, we can get a reasonable chance of a successful pregnancy. It's not just about getting pregnant, it's also about a healthy baby. And the single biggest risk for fertility treatment is a multiple pregnancy. Our singleton pregnancy rate through our practice is 98%. We have less than 2% incidence of twin pregnancies, and that's simply safer for mum and baby. 1 at a time is safer. We get a high incidence of full-term normal weight babies, which is not what you see for IVF treatment. So we do get healthier babies because of the treatment we implement. And because we take a restorative approach and the woman's health is improved, the factors that we're interfering with her ability to get pregnant also put her at increased risk of a premature delivery and low birth weight. So if we've identified and corrected those, she's much more likely to go full term and have a healthy baby. We can also treat men, and up to 50% of the time, we can improve male fertility. And we look at, in particular, the sperm count, the sperm motility, and the DNA fragmentation index. Sadly, we're not an option for guys with 0 sperm. You need to have some sperm present. And if the count is persistently below the 1 million mark, we're unlikely to achieve success. The average sperm count at the lower end of a normal sperm count should be 15 million. But we've had repeated successes with couples if we're anywhere above the 1 million mark. So how do you compare restorative reproductive medicine with in vitro fertilization? Because many would argue you're trying to compare apples and oranges here. IVF is just 1 single cycle, whereas restorative reproductive medicine, it's a process over 12 cycles. So how can you compare the two? They're really quite radically different. And I would argue, well, you got a whole load of couples who present for treatment and they want to have a baby. How hard can it be? Lots of couples trying to get a baby. How many couples get a baby? How hard can that be to compare? So the challenge is a lot of IVF data is obscured, because even if you go to the authoritative Human Fertilization and Embryology Authority to look at their data, It's really hard to get clear, simple data. What we want to know per cycle, per 100 couples who would start a cycle of IVF, how many live births do you get? And this is to some degree hidden in the HFEA data. It's not immediately obvious and you have to dig deep to look for it. I've gone right back to 2012 data in order to be able to get this information because it's not currently available in the current format. So what we want to know is how many live births do we get per cycle started, and the numbers come out, it's 1 in 4, which is down at below 25%. The problem is a lot of the fertility clinics quote clinical pregnancies per embryo transfer. So couples who don't get to embryo transfer are just subtracted and excluded from the data analysis. And then couples who have a clinical pregnancy that ends in miscarriage aren't included. And what this means is, from the data here, there was about 47,000 couples who started. 6,000 couples were excluded because they never got to embryo transfer. A further 3,000 couples were excluded because they had a clinical pregnancy, but not a live birth. They just simply subtracted that from the calculation. And if you look at clinical pregnancies per embryo transfer, then you get a 1 in 3 live birth rate, which it's true, but it's a little bit deceitful in the reporting of the data. So 19% of the couples were just excluded and vanished as if they didn't exist. And how many couples lose their pregnancies if they have a clinical pregnancy with advancing female age? This is from the official HFEA data published in May of this year. You could see that the numbers of clinical pregnancies ending in miscarriage get significantly higher with advancing female age. So this helps to give a sobering bar chart to demonstrate the green bar is the number of cycles started. The blue bar is the number of clinical pregnancies, and the yellow bar is the number of live births. And you can see that those blue and yellow bars are barely visible at 43 plus, and at 40 to 42, they're substantially lower than the number of cycles started. If we look at the live birth rates by age, these are the actual numbers from the most recent data available through the HFEA. And you have a 31% live birth rate per 100 couples who start a treatment cycle, dropping down to a 4% live birth rate if you're 43 plus. This is not what IVF clinics quote, because they quote clinical pregnancies per embryo transfer as opposed to live birth rate by age per treatment cycle, which is the data people really need to know. If we compare, the most punishing way of comparing our data with the official IVF data, we compare favorably. So we looked at our data from 2015, and we had an overall 32% crude live birth rate. This means for every couple who started treatment in our program, how many had a live birth at the end of the process, and we included everybody who had 2 medical appointments or more. If you only come to our treatment for 2 appointments, then you're quitting far too soon if you don't return for a 3rd, 4th, and 5th appointment. But to show our real numbers and to be as punishing as we could in our data, we included all those that we refer to as early quitters. This is a treatment process over time. If you discontinue the treatment prematurely, you're going to have a lower success rate. And if we included all of those, this is our worst data possible, compared with the IVF crude live birth rate and comparing the different ages. So we do compare favorably, and our data would be superior to a single round of IVF. This is the way our numbers came out. We had 412 couples who attended for 2 or more consultations. We had 132 live births. We had 21% of our couples had previously tried and failed in vitro fertilization. We had 1 multiple pregnancy, so it was less than 1% for that year, and the average female age was 37. So a challenging group, more difficult than your average couple that would present for IVF based on our data. There is a recognized system called live table analysis that you can use taking into account the early quitters. So if, for example, those who have quit after just 2 medical consultations, if they persisted for a 3rd, 4th, and 5th consultation, and if they had the same conception and live birth rate as those who stayed with our program, this is our calculated live table analysis. And this is a way of trying to correct for those who have quit too early. So we got independent scientific researchers to review our data, and these are the data that they came up with. And they showed, well, using live table analysis, this would be the predicted live birth rate if couples continued for 12 effective cycles. And we compared this with the IVF data. And then we also did a comparison using a similar calculation technique, looking at cumulative live birth rates with assisted reproductive technology cycles. That's using IVF. And this is the New England Journal of Medicine, published in 2009. And we compared our data with 3 rounds of IVF, which is a process over time, which, bear in mind, using Irish money, it's a minimum cost of €15,000. I'm sure it's 30,000 US dollars, because it's about 10,000 plus for a single round of IVF in the United States. Cost wasn't an issue for these couples because, as it turned out, their insurance companies covered all of the costs. Here's how the data compares, and this is using their optimistic interpretation if everybody continued using similar calculations to ourselves. So what it shows is we're very broadly comparable to doing 3 rounds of IVF. And these are calculated figures for both in vitro fertilization as well as for our approach. But they compare in a very similar way. So restorative reproductive medicine is any medical or surgical treatment that restores optimum reproductive function. So we use a combination of medical and surgical treatments. The key thing that differentiates restorative reproductive medicine is we work with a fertility chart. We combine this with detailed hormone assessment in the way that I described. And something I didn't describe is we use multifactorial medical treatments. The basic treatment is hormone assessment and balancing, but there are a multitude of additional medical treatments that we implement that it's too detailed to go in with for you today. We combine it with ultrasound follicle tracking. Once we restore your cycle, we verify by ultrasound that the egg is definitely being released. We do detailed assessment and treatment of the male factor. We implement skilled surgical treatment where needed. And a key component for us is psychological and emotional support. And the final part of the equation is this is a process over time. Everybody agrees it is normal to take a year to get pregnant. So once we assess and balance your cycle, we allow a couple to engage in a loving embrace in a pleasant environment for up to 12 cycles to allow that fertilization may come into this pleasant space. In vitro fertilization, by contrast, it's a scientific process that is outside of the loving embrace. So the couple provide the sperm and the egg separately. The scientist unites the sperm and the egg and then grades the embryos that result from that union, and the embryos that make the grade are then frozen or transferred at the appropriate time. But it's a completely different methodology for trying to help a couple with a fertility problem. And of course, it raises the issue of multiple excess embryos, embryo freezing, embryo storage, and these additional conundrums. So our overall process of treatment, we work through 3 phases: phase 1, phase 2, and phase 3. So phase 1 is assessment and preparation, where you download the app, you start recording your fertility cycle, ideally work with your fertility advisor and get the necessary blood tests on day 3 of the cycle as a once-off assessment. And 7 days after you ovulate, let's interpret the quality of your ovulation. We do this for 2 cycles. Phase 2, you have a review with your restorative reproductive doctor. You then engage in a process to balance your cycle, hormone balancing, and multiple additional things that I haven't even covered that are relevant for general health as well as fertility. That also takes about 2 cycles. So it's about a 4-cycle lead-in time, sometimes 3 cycles, but it takes 3 or 4 cycles of assessment and balancing. And then we graduate to phase 3, where we say, now that we've achieved a balanced cycle, you're feeling good, your fertility pattern looks good, your bloods are balanced, you're ovulating by ultrasound. Now enjoy the process. You laugh, you relax, you enjoy, you allow fertilization to occur, when you identify the fertile days, you laugh and enjoy those days. Its frequency of intercourse is every second day. It's not every single day, although sometimes every single day suits, but do not allow the chart to become a dictator that puts you under duress. Rather, the chart is a friendly indicator, and then it's a case of allow this to happen in its own good time. Every month, continue to monitor your hormone levels so we can make sure we maintain this healthy, balanced cycle. So let's try and give a practical comparison of 2 couples who presented to treatment. They were both in their early 40s. They'd both been pregnant on 3 occasions. They both had 1 previous baby followed by 2 spontaneous miscarriages. So they had their live birth a few years earlier, which was full term without any problems. And then they had 2 consecutive miscarriages. And as it turned out, both separate couples were found that when they did chromosome analysis on the miscarriage, they found that there was a chromosomal problem with the baby. So they presented to the doctors and presented to us. And they said, "Doctor, what are my options? What can I do? I'm now 41 and I want to know what I can do for treatment." Well, there's 2 ways of approaching this. One is in vitro fertilization and the other is restorative reproductive medicine. And we gave our approach, and the fertility clinics they had attended each gave this approach, where they recommended in vitro fertilization with pre-implantation genetic screening. They would go through ovarian stimulation with egg retrieval, fertilize the egg outside of the body, identify the embryos, take a cell off the embryo, put it through scientific analysis, and then the healthy embryos they would put back. And they quoted a 30% success rate, which is clinical pregnancy per embryo transfer, but the HFEA tells us the live birth rate per 100 couples is about 11%. Whereas with our approach, we would say, well, we want to go through a process of discovery. Why have you had these 2 losses? We want to treat any premenstrual syndrome, fatigue, anxiety. We want to balance deficient reproductive hormones. Recommend strategies to improve both sperm and egg quality. And after we've achieved all of this summer, after 3 or 4 cycles, then we want to allow you to conceive through a loving embrace. There's no embryo grading or embryo wastage, and we'll give you a solid 30% live birth rate, which is a real number per 100 people who would start. So that's where we were at, and this is the reason we were a little bit higher on this compared to our usual numbers is because these are couples who'd a proven ability to get pregnant 3 times before. This isn't infertility. This is impaired fertility with 2 miscarriages and a chromosomal factor identified. We improve sperm quality, we improve egg quality, we boost and balance the hormones, and then we get as healthy an environment as possible. And we'd be confident we'd be higher than our average. If we're dealing with infertility for a couple who have never been pregnant before, then we would be at a lower rate. In fact, it'd be more around a 20% mark, but we're up at 30% because of that, 30% plus. And we need bigger data and more numbers before we can be absolutely certain. We can never give a guarantee. I wish we could. But if we take this restorative approach, we'd be confident we'd be superior to an IVF approach for a fraction of the cost. We know that we're going to have a lower incidence of twins, and we know we're more likely to go full term with a normal weight baby and healthy baby. So when we compared these 2 approaches, this is the couple one couple had in fact already tried and failed the in vitro process by the time she presented to us and is now embarking on our approach. And the other couple hadn't yet tried in vitro, but decided, well, let's go our direction. And this is their chart on the cycle of conception. So we have a record here that we gave them medications to stimulate the follicle, a trigger injection to release the egg. They identified the good quality mucus. They'd intercourse at the right time. We could tell from this that she ovulated and conceived on day 10 of her cycle, not day 14. So when we're assessing her hormones, we check her bloods on day 18, not day 21, to interpret the quality of her ovulation, and she conceived with fantastic levels of estrogen and progesterone. She had her positive test 16 days after her presumed ovulation. We checked her hormone levels for the early stages of pregnancy, and the hormone levels were fantastic. So through a process of cycle balancing, before we had put her on this treatment, she had very low hormone levels, and it was a little surprising to us that she was able to get pregnant quickly and easy because her hormones were really quite poor. We also did detailed assessment of the male DNA frag, and we improved the male factor. We put him on treatment. We had her on supplements, as well as balancing their hormones. And we also implemented some immune modifying treatment as well. So sadly for the couple who presented to us who tried IVF, it didn't work for them. And in fact, they went for the pre-implantation genetic screening. They had no embryos left to put back. So, so the story with them was the IVF statistics would say this couple never even existed because it was not a clinical, they never got to embryo transfer, so they're not included in our analysis or documentation of our failure rate. So they don't exist in the IVF clinics data, except the HFEA does show it. They're the wrong side of 11%. So the couple with us, they conceived in their third balanced cycle. This is 7 weeks and 2 days gestation. And the crown rump length, we measure the top of the head down to the bottom. The embryo is measuring 1.1 centimeters. And this part never gets old. Hope it plays. There we go. So there's the little heart beating away very nicely. And it's a lovely thing to see. 1 centimeter of newborn life, the heart beating away. And the baby, there's the head, the heart, and the bottom. And we can tell from this and her hormone assessment, it's very, very likely this is a healthy embryo, because you conceived with good hormones. We got you both healthy. You had a baby before. Yes, you had a baby with a chromosomal factor before, but because we've improved sperm and egg quality and balanced your hormones, we'll give you the best chance we can of conceiving successfully on your own. And this couple, as it turns out, are now above 30 weeks and everything is going very well. She's now 42 and we're expecting good news for delivery any day now. So couples' experience with our approach is generally very positive. So we've got no shortage of positive testimonials about how they're treated in a human way, how it's a restorative approach, and how this is very much consistent with what they want. And very often we find couples when they go to a fertility clinic are presented with something like IVF with pre-implantation genetic screening and no other way of assessing, where there's a whole world of additional treatment that we can recommend to couples. And so we get testimonial after testimonial that we've put on our website that you can read about couples' different stories. But this is one of my favorite ones, a lovely couple who had 2 failed IVF. Her egg reserve was low based on a blood test for low AMH. And they were told, we're done with IVF with your own eggs. The only option left to you at this stage is donor eggs. So they presented to our practice when she was either 37 or 38, and this was their story. And we implemented our restorative strategy. We gave them an outline of here's how we will approach all of this. And one of the things you need to bear in mind when you're advised donor eggs is there's no rush with that, because the success rate with donor eggs is going to be the same in a year's time as it is today. And I would have explained, well, the pressure is off because we can take our time with this. Yes, we want this to work as quickly as we can, but there's no pressure because you don't have to be rushing for donor eggs. And hopefully we're usually both in agreement that we can help you avoid that. And as it turned out, they went on, had 3 separate successful pregnancies in her program. She just recently delivered her 3rd baby. They give their testimonial on our website. We never pay anybody to give their testimonial. We ask, would you mind sharing your story so other couples could be aware that there's another way? And they're more than happy and quite enthusiastic to do that, along with 2 other couples. But it's just to say that it's a very, the critics would argue we don't have enough scientific data to prove this. And in truth, they are correct. We don't have enough data out there. We have clinical experience, we have some publications, but we know from our clinical experience and our scientific assessment, this is a very reasonable approach for people to try. We're trying to make this approach available in the United Kingdom, and we're working on that. And we would hope, with the help of Frida as a fertility advisor and Nell, who's taking this on as a fertility doctor, that we would be able to make this available to couples in the United Kingdom who want it. We have significant challenges making it available because of difficulty getting blood tests through the NHS and ultrasound scans and the different approach with restorative reproduction. But with patience and perseverance, we hope that we'll be able to convince more doctors that it's a very reasonable thing we're trying to do here. And if you put aside less than half of the budget that you'd ordinarily recommend for an IVF cycle and divert that towards what we're doing, I think you'll find that we're far more cost effective on multiple levels, not just to get pregnant, but minimizing the complications for premature delivery and the additional costs that go with that as well. So I hope that gives you a reasonable overview of what's involved with restorative reproduction. And I expect that you'll have plenty of questions that Frida will hopefully be able to explain the practical implications of this and how to access this in the United Kingdom. So thank you for listening, and I wish you all the best. Bye for now.